think the biggest pro from this podcast was actually really harping on how men need to be aware, and their physicians and NPs also need to be aware that finasteride will affect the PSA. And then the most recent one was Dr. Schaefer, who is a medical doctor and also has a PhD. I believe he is sort of zeroed in on the epigenetics of prostate cancer and in sequencing these samples and these cancers, trying to get closer to a precision medicine approach, which is pretty cool. He's doing good research. I think the biggest pro from this podcast was actually really harping on how men need to be aware, and their physicians and NPs also need to be aware that finasteride will affect the PSA. So if you are going to a pop-up telemed clinic and you're taking your finasteride and that's not being pulled into your physician's EHR, then you could have a PSA that's rising and no one's aware of it, and then you're going to have a higher degree, a higher grade of prostate cancer. So empowering men and taking ownership of this, and then definitely informing your physician or NP of everything that you're taking, super important. And I'm glad that he brought that up.
Yeah, it's not uncommon to see a PSA drop by 50% or drop in half. So if your PSA proceeding is 6 and you're borderline between getting a biopsy or doing expectant management and it drops to 3, then that's expected. But if it stays at 6, then it may as well have doubled to 12. So that's a very good clinically significant takeaway.
Yeah, I think so. And next we had his take on finasteride, which he said he doesn't prescribe, never prescribes it in his practice. I don't know if this is just a result of some bad patient encounters. It sounds like he has a plethora of other medications he uses for lower urinary symptoms, and there are procedures that can be used there. So he's chosen in his practice to simply avoid prescribing any 5-alpha reductase inhibitors. And he said it was also sort of a scam to take daily finasteride because that 5 milligram dose would hang around for a week or two. So if you're looking at some of the single dose studies, it looks like, after a week, you're still going to have a statistically significantly lower dose or lower amount of DHT in the serum. Caveat here is we really don't know how much is in the scalp.
Yeah.
I don't think there's any volunteers out there who are going to take a dose of finasteride and then get 7 scalp biopsies over the next week. So we probably won't get that answer. But based on the serum levels, this makes about as much sense as taking your Repatha every other month. While you still may have a lower level of LDL and ApoB, you're really not going to be getting the longer, lower level over a period of time.
Yeah, there'd be a huge peak and trough. So once a week, 5 milligram finasteride, certainly do not recommend. Just as we do not recommend Repatha every 3rd month or a injection of testosterone cypionate every 3rd week.
Yeah, it looks like if you followed a protocol of 5 mgs once a week, you would kind of dip down initially to DHT of about 25, someone with an average DHT level to start, and then it would slowly climb back up to what looks to be about 45 by day 7. So that perhaps he misspoke and meant to say dutasteride, which we know has very different pharmacokinetics.
Yes.
But there wasn't a lot of discussion of dutasteride in either podcast.
And to play devil's advocate, yes, even after you got to a steady state of doing this for a couple months, you would still peak and trough. It just would not, it obviously wouldn't peak and trough to 50 and 25. It'd probably peak and trough to 15 and 40.
Yeah. And then here's what you were mentioning about prostate cancer. And, even though type 2 is the predominant 5-AR enzyme in the prostate, let's say the normal prostate, the one without cancer, things change and get scrambled in a number of conditions, prostate cancer and BPH. So why is this important, and why might this steer someone towards either dutasteride instead of finasteride or even a combination?
Yeah. The intrachronology of the 5-alpha reduction of various androgens can be upregulated. And it is known that the newly discovered, it's now no longer newly discovered, this paper is from, this is Yamana et al. I believe it was from about 10 years ago. But the newly discovered type 3 5-alpha reductase has higher expression levels than type 1 and type 2 in most peripheral tissues and prostate cancer, and in fact, breast cancer cell lines. I wonder if they were talking about androgen receptor positive, triple negative breast cancer. I'm not sure on that, but certainly of prostate cancer cell lines. And it suggests that type 3 plays a very important role in these tissues. So the takeaway is that if you're not inhibiting type 3, even if you're inhibiting type 2 and type 1 completely, or if you're not inhibiting type 3 very strongly, then you're having a lot of androgen-mediated growth of that prostate cancer. But didn't they say that type 1, or didn't they say that finasteride is an inhibitor of type 3?
That's true. The same paper found that finasteride does in fact inhibit type 3 to some degree, but not nearly as potent as dutasteride. And we'll run through those numbers. He also commented on post-finasteride syndrome, which is, sort of gaining some ground, gaining some traction and attention. And the figures he threw out were somewhere between 5 and 15%. He didn't say that I'm saying it's between 5 and 15%, like me, Dr. Schaefer, this is what I think it is. He said some people will tell you 5%, some people will tell you 15%. If we split the difference, then that's 250,000 men who, just based on last year's prescribing numbers, would have permanent sexual dysfunction. And I think that's a drastic overestimate. If we say it's 1 in 10,000, I think it'd be fair to say, yeah, some people will say it's 1 in 10,000. Some people will say it's 15%. Like, you'll have people on all extremes. And if you go onto some forums, some people will say it's 100%.
Yeah. What I would say is it depends on the patient population that you are selecting for. So if you stratify the patient, not just based on objective data, so not just based on labs, but also based on history, family history, predispositions to already have side effects that finasteride can induce, then you're going to have, you can select that patient population and know these individuals are very likely to have side effects, whereas others are much less likely to have side effects.
Yeah, so you talked about baseline lab work, screening for anxiety, screening for depression, family histories of both of those, especially in first-degree relatives. You can get a drastically lower outcome or lower bad outcome, and you can see who's a good candidate and who is someone who, at this point in their life, probably shouldn't take one of these medications or certainly shouldn't take it at full strength at this time. He did mention that there are alternatives to finasteride. He talked about his own experience balding at a young age, and he suggested that young men could pursue a hair transplant instead, which isn't quite apples to apples. A transplant may cost in the 5-figure range, and finasteride is, if you go to Mark Cuban's pharmacy, less than $50 a year.
Yeah, and Thor has had a few hair transplants as well. I know he talks about it on the social media. So some people do just have hair transplants, but if you're starting to have androgenic alopecia at an early age, then you only have so many potential hairs for grafting. And eventually you're not going to be able to continue to have hair transplants. And if you continue to have fast progression of your alopecia behind where they graft, and yes, if you have a better surgeon, they'll graft it in so that you're going to have a longer time to notice progression of alopecia of your non-grafted hair. But still, it can become quite obvious if you have fast progression.
Yeah, is these the ones where you see sort of a floating island of hair at the hairline and then a bald scalp and crown area? So definitely something to consider there. Transplant, especially when it's done younger, more than likely you're going to have to go back and have repeat procedures if you're not taking medication as a preventive. So what are some of the risks of kind of broadcasting, what in our opinion are kind of inflated figures of how many people actually have, and we're not talking about just a transient side effect, we're talking about a permanent syndrome is what they're calling it. So, saying that, yes, 1 in 10 men are going to have this. What are some of the downsides of broadcasting this inflated figure?
The nocebo effect is certainly very strong. It is a well-known effect where it's similar to placebo, except instead of getting the benefit with nocebo, you get the side effect. And now that the people Google side effects of finasteride, and then post-finasteride syndrome will pop up, And it's good to be aware of and to discuss with your healthcare provider. But a lot of individuals that are discussing this with their healthcare provider, they still have not heard of post-finasteride syndrome, although I think a lot of them have been in the last year. But it is leading to more nocebo effect and more individuals thinking that they have either a finasteride syndrome or a post-finasteride syndrome that otherwise would not have those symptoms.
Yeah, I mean, you're definitely creating a spike of anxiety in some individuals. There's sort of 3 levels to understanding drugs and drug side effects. There's like, if you're blissfully unaware, you're very rarely going to have side effects from medications because, typically common medications, they don't have a ton of side effects that come along with them. And then you sort of have this middle ground where people are aware of medications and side effects and they do their research. And that's your group that is most likely to get side effects. And you get to, let's call it level 3, where you understand side effects, you understand how often they happen, you understand they happen in placebo, and you understand the nocebo effect, and you can sort of reason through all those things and not overthink it. I suppose we call that side effect enlightenment. Then you can kind of see through, okay, maybe this stomach ache or this headache I got today isn't that pill or that supplement that I just took. I'll see if it happens again, next week, something like that.
Yeah, it's the Punnett square of health. And again, what the Punnett square of health is you want to be in the category where you're being objective about things and making smart decisions about what tools and lifestyle changes you implement. But you also don't want to catastrophize about things. You don't want to take on the sick role. And often those that do think that they're choosing between impotence and having hair, that is certainly something that can be associated with healthcare trauma and taking on the sick role, especially an individual who would otherwise greatly benefit from, think of a perfect candidate of a 5-alpha reductase inhibitor. Maybe they're not a great candidate for finasteride, but maybe a very small dose of dutasteride would do this individual a lot of good. Perhaps they're on TRT, a steady state level of an androgen. Perhaps they have left ventricular hypertrophy. They have cystic acne. Their hair also happens to be thinning. They have BPH, and they're very high risk of prostate cancer. Maybe they even have let's say they have a prostate cancer that is very, very low Gleason score, and they're doing expectant management of it. They're literally a perfect candidate. And maybe they're scared off of taking dutasteride because their healthcare provider says you need to be very cognizant of taking both finasteride and dutasteride. So there's certainly potentially harm to both overestimating and underestimating the potential for finasteride side effects and post-finasteride syndrome.
Yeah, and that's a great point. Someone who has a known prostate cancer, I mean, if you're 50 years old, I think it's about a 50-50 that you have at least some atypical cells or maybe a low-grade prostate cancer. And whether that's going to ever cause a problem, a lot of that is hereditary. If you look back at family history, exposure to carcinogens, and then how many growth factors you have, different vectors that are going to accelerate that growth. So for that person, and this has actually been studied, like you take dutasteride, you have both a lower prevalence, a lower incidence of prostate cancer occurrence, and then also slower progression, not zero progression, but it's very unlikely that taking even a low dose or a daily dose of dutasteride is going to cause permanent sexual dysfunction. What's much more concrete is if you have a prostatectomy, a tremendous amount of those patients are going to have permanent sexual dysfunction from that.
Mm-hmm. Yeah. I think that's a pretty good summary of potential downsides of overemphasizing side effects from finasteride and dutasteride. Another thing that kind of occurred to me is if an individual is, let's say they're on a supraphysiologic level of androgens or TRT plus, whatnot, then they should especially consider it. Even its effects, just like there can be some deleterious effects on your cognitive functioning, your prefrontal cortex certainly is responsive to DHT and has a high level of 5-alpha reductase. If you have too much of that androgenic pool, you'd be drunk with your androgens, which could essentially be considered roid rage. And yes, taking more or less androgens does not change who you are as a person, but it can certainly shift you along that continuum of neuroplasticity to where that could be a benefit for some individuals.
Yeah. I mean, if you were on TRT and lost half your hair and your fear was that if you took anything, you were going to get post-finasteride syndrome because, hey, it's a 15% chance I get this. That person may be pretty angry listening to this.
They certainly might be.
Yeah, it kind of reminds me of we'll call it a bit of hysteria over statin medications and the amount of side effects there. There's been some really interesting studies there, introducing these, reintroducing these, doing these blinded, and seeing that it's really not 15 or 20% of people that can't tolerate statins. But even so, this is circulated online, and now many people are very statin hesitant, and people that would benefit from a much more common condition and a much more life-threatening condition, cardiovascular disease, or not taking medications that would probably benefit them.
Certainly. And our local lipidologist, Dr. Moriarty at KU, deserves a lot of credit for publishing all sorts of strategies to help those who are previously statin intolerant tolerate statins at a very high percentage of success. So not to rabbit trail on that too much, but that's a good analogy.